Can you give us an overview of what your talk was about?
Really, in summary, there's one thing that's really important to me, and this is the fact. Glaucoma patients deserve good vision. And so I think so many times in glaucoma, what we do is we're so focused on lowering IOP and even the optic nerve, which are very important things, but we forget about a lot of things. The ocular surface, okay? We know that these topical medicines are very toxic to the surface. A lot of times the meibomian glands are severely damaged. We also, when we do a lot of our procedures, for instance, trabeculectomy or tube shunts, guess what? We're ending with multiple levels of astigmatism. A lot of times they'll have a little myopia or hyperopia, depending whether or not they have hypotony or not. And guess what? It really makes these patients feel like, man, the quality of their vision every time you touch them is getting worse. And I really want to change the paradigm of how people think about this and how we as physicians approach our patients.
So how, well, obviously it's prevalent because it's obvious nature of the beast, but what can clinicians do when they're doing, just before they're doing a surgery, to keep that in mind when they're doing the surgeries?
Well, I think doing a good ocular surface evaluation, whether it's meibomian gland imaging, Schirmer testing, also just looking at the staining of the cornea, really, really important. And then I'll just tell you, when we're doing cataract surgery, we know that about 20%, 15 to 20% of all of our patients that have cataract surgery also have glaucoma, and that means they're oftentimes on medication. Well, guess what? We can put in lenses such as toric lenses. We can also use even extended range of vision lenses. And when we approach it that way and then use MIGS procedures, all of a sudden, not only are we lowering intraocular pressure and protecting their optic nerve, we're improving the quality of their vision.
How important, it's definitely taking the next step more, is how prevalent is it in terms, or how much more should the physician be aware of when he's dealing with premium IOLs?
And here's the thing, I would just tell you, in the past when we talked about presbyopic intraocular lenses, they really reduce contrast sensitivity, and they're really not probably the best choice for people with glaucoma. Well, I'm going to tell you right now, with mild to moderate glaucoma, where they really have good vision, maybe just have a nasal step or something like this, I can tell you right now, these newer lenses do not have the same decrease in contrast sensitivity. So really, by not putting them in their eye, guess what? We're taking away their near vision, their intermediate vision, and we're also not always addressing their intraocular pressure as well as we can, because we're maybe not using the MIGS procedures that can really add to the improvement of their IOP control.
One final question, Dr. What's the take-home message for the clinician?
Well, again, I want to just say glaucoma patients deserve good vision, and I also just want to, as a kind of a corollary to that, don't forget about using corneal refractive surgery with either LASIK, PRK, or even the newer procedures such as SMILE, because there are patients, especially people that can't put their eye drops in or can't put their glasses on. I think of quadriplegics, even some of these Alzheimer's patients. We have a procedure that literally takes seconds, and their quality of life is drastically improved when their vision, because they're not going to get their glasses on. And we've seen from studies, believe it or not, that when people see better, guess what? Their mental status improves.
Thank you, Dr. Vold, for your time. Appreciate it.
Thank you.